Okay, so I think we can start now. Those who joined the session recently, good evening, welcome back. I hope you guys are doing well. Just a minute, 48, okay. Okay, so I think we can proceed with the session. I hope you have seen the module title in the link. Okay, today we are entering into a very important and I can say slightly advanced area of whole antimicrobial stewardship. Okay, it is not that advanced, but it is slightly advanced, I will consider, because this is the topic, on the basic stewardship, no one is discussing. Okay, because it is one step ahead, okay, one step above it. So, how to truly interpret the culture and the susceptibility report? That is our topic of the discussion today. Very important, very interesting, and it definitely increase the curiosity of us to read the antibiogram reports and what exactly breakpoints is all about and all. Many of you might be attended our previous free webinars on how to read antibiograms and all. So in that webinar, I had discussed briefly about the antibiogram and all. But this session is, it is starting from the very basic level to slightly advanced. Okay, so how to truly interpret the culture and how to exactly assess the susceptibility report, AST, that is antimicrobial susceptibility report, how to do it and how to correlate it with our clinical setting. That is the topic of the discussion today, right? So this lecture is, I will say, not about, this is a disclaimer for you that this session is not about memorizing drugs. Why? Because this module will have multiple cases in the discussion. Okay, some of the real cases as well. Okay, prescriptions as well, reports as well, to understand the resistance pattern and to understand the susceptibility reports. Right? I need to include a lot of case, lot of treatments and the reports as well. So we will be having many examples in between. Okay, cases examples we will orally discuss. Some of them is written in the PPTs as well for your understanding. So do not think in this, in this lecture in the therapeutic way. Okay, it is very important to correlate everything at the end when we are talking about the stewardship things. There is always a correlation of pharmacology, therapeutics, and toxicity, toxicology altogether. But still, the purpose is very clear. The purpose is here not to memorize the drugs, guys. Okay, it is about thinking like a stewardship pharmacist. Okay, so our purpose is very clear. We are here to understand stewardship principles. Okay, so how to monitor, how to report, how to handle, how to cure, how to prevent, those are our topic of the discussion, not the therapeutics. We are not here to memorizing drugs and their mechanism of action. Obviously, we will try to connect the dots. And I will little bit assume that you know how some basic drugs mechanism of action is working. If you have doubt, we will solve it at the end of the session as we are, practicing till date. Okay, so don't worry, but it will be slightly advanced level. Okay, so you will be thinking like a stewardship pharmacist, where you can connect all of the branches, that is microbiology, pharmacology, and your whole clinical judgment. Okay, so by this end of the session, you should feel, more confident in what? Reading culture reports instead of just, accepting whatever is written as a sensitive or resistance. Whatever you have practiced is this: S, I, and R. Okay, intermediate, sensitive, resistant. Everyone has idea that biogram has this SIR report, and we are interpreting based on it. But as a clinical pharmacist, we are not here to only interpret, guys. We are here to make changes. We are here to advise changes. We are here to monitor treatment. Okay, the effectiveness of the treatment. For that, you must be very clear with the fundamental things related to this sensitivity reports and the whole interpretation of the antibiogram. Right? So you are not only able to interpret it, but you need to correlate it with your clinical judgment. That is the learning objective behind this particular module. I hope it is clear to you. Is it? May I know? Is it clear what is coming in the session? Because that why should be very clear before I start with the PowerPoint presentation. Okay, okay, I'm very happy to see your reactions. Okay, we can now deep dive into the PPT. Just a minute, I'm sharing the screen. I hope the screen is visible to you. Screen is visible to you, right? See, guys, this is the online session, so you must be, proactive little bit so that glitch, if in between any glitches are there, we can solve it, right? Feel free to drop a message if you are not, if I am not audible enough or if the screen is not visible in between. Feel free to drop the message in the WhatsApp group as well, though that group is for us only, right? So do that. Just a minute. Here. Here is the title. I hope now it is clear and making sense. Advanced Cultures and Susceptibility Interpretation. This is the module number 4 of our Advanced Microbiology Stewardship. And till this module, guys, module 1, 2, 3 was all about the basic parameters, basic things what we already, might be knowing somewhere. Okay. But this is something which comes under the advanced side, slightly advanced side. Now we are, jumping into the our main title, that is the advanced antimicrobial stewardship, those concepts which are not generally discussed into detail. Okay, so in the courses basically, but this is the 6 months course, so I designed this particular course in a way that it can be actually useful in the practical scenarios while handling cases, right? So this is the title of our module number 4. We will start as our practice, we will start with why. Okay, first, we will understand the importance of the topic, why this lecture matters, why we are understanding this antibiogram things and susceptibility testing and all. See, guys, many treatment, fail. Why many treatment failures happens? Why? Because not the antibiotic was wrong, but it was because the report was misinterpreted, right? And we are here as a clinical pharmacist or future healthcare professionals. We are here to save people. Okay, we are here to work on approach that is patient centered. Everything is evolving around patient centered. Our goal is not to counter anyone. Our goal is not to not to make competition with someone, right? Our goal is patient centered. Our goal is at the end, we want to increase our therapeutic effectiveness of the people. We want rational use of the drug. We want quality use of medicine. Okay, this is our aim. This is our goal at the end. And that is the goal we are working in the direction, right? So many treatment failures are happening not because the antibiotic is wrong, but the report was misinterpreted by the clinician, physician, and the healthcare professionals. So, as a pharmacist, as a clinical pharmacist specifically, we are often, the last safety checkpoint before the antibiotic given. Okay, we are the last, I will consider as in last safety checkpoint before any antibiotic is given to the patient. So if we don't know about this minimum inhibitory concentrations, MICS, resistance mechanisms, antibiogram, how to read antibiogram properly, we may also unknowingly promote resistance even while trying to help the patient. Okay, unknowingly we are also contributing into the resistance if we don't know the resistance mechanism and how to read antibiogram properly. Because if you don't know this concept, you cannot suggest any physician or clinicians to change the treatment because they need evidence. Okay, they need explanation. Why do you want to change? Right? So wrong interpretation leads to wrong therapy. Direct impact is on resistance and the whole treatment outcome. And pharmacists are here to bridge this, the gap, okay, between the lab and the clinic. You must be knowing how to read the reports and you must be knowing the clinical judgments as well. Okay. Now, have you ever seen a patient not responding despite a sensitive antibiotic, guys, in your practice? Yes or no? बहुत बार ये चीज होती होगी. Many times it is very common, right? It is very common. Like, have you ever seen a patient not responding despite the report is showing it is sensitive antibiotic? Because this is very common scenario. Okay, sensitive means if the if it is not a known concept to you, let me just brief you about what antibiogram is all about in this slide only, so that this is slightly advanced level, so might be little bit confusing. It sounds confusing to you, so clear the concept from this slide only, right? Understand, antibiogram is a report. Okay, it is a report which gives you idea in the particular patient which antibiotic will be sensitive, which can be intermediate, and which can be resistant. Okay, so the report has S, I, and R into it. That is very common. Okay, if the report is suggesting cephalosporin S, that means good to go. You can use cephalosporin in the particular patient. If the report is showing R in the cephalosporin category, you cannot use cephalosporin in the particular patient. It will be resistant. Okay, so this is how the report has S, I, and R into it. But even some cases are there. In fact, many cases are there when the antibiotic is having sensitive, that means good to go, but still patient is not responding with the particular medicine. This lecture explain the reason behind why. Okay, why this is happens, that even if sensitive, it is written sensitive, still the patient is not responding to particular medicine. Okay, that's where stewardship begins, guys. That's where you are standing. This is your position to solve this matter. Okay, you need to be very clear with the concept related to the resistance. And trust me, guys, we cannot learn stewardship in the 6 month or 1 year. It is a continuous process. I am here to show you the direction of learning. Okay, what to learn, what to take updates on daily, right? We need to follow current affairs in the pharmacy. For resistance strains, we need to update ourselves on a daily basis what is happening in the field of pharma. What are the resistance strains in the community, how we can solve it, what are the moieties are there, which chemical moieties are under pipeline. These all are the things you need to take care of. Okay, it is a continuous process. Stewardship is a continuous process. So what is the learning objective for the particularly this session? Understand, now the why is clear to you, so now you can relate the all the questions related to the learning objective. Your answers are here. So today we will focus on five, or this five bullet points. You can see here the five major concepts are written here. Okay, we will focus on this five key skills I will consider. First, by the end of this session, you will be able to interpret what is MIC and MIC CRIP is all about. This is two different concepts, thin line difference in it, but you will be able to understand by the end of this session how to interpret minimum inhibitory concentration and minimum inhibitory concentration CRIP. Second, by the end of the session, you will be able to identify what is this extended spectrum beta lactamase, ESBL, what is this AMPC, what is inducible resistance. Okay, sounds, many of you might be aware of it, many of you might be not aware of it. Don't worry. This lecture is this lecture is about to solve this questions queries related to these concepts, and you must be knowing it, right? So by the end of the session, you will be able to identify as well. Third, you will be able to understand the breakpoints, especially CLSI versus EUCAST. I will let you know what it is in the upcoming slides. This will be our last topic of the discussion. And fourth is very clear, that is reading antibiograms like an expert. Okay, I will show you the slides how students are reading antibiogram, how experts are reading antibiograms. There is a huge difference between the two different reading a same report. Okay, so you can compare and you can start recognizing how I should read the antibiogram and what my duties are all about, because pharmacist itself is not aware of what are the roles and responsibilities of us. Okay, we are not here to just look at report, interpreting it, and blindly following the treatment. We are here to intervene. We are here to suggest. We are here to identify. We are here to monitor, and everything is depend on how you are reading the report. Okay, so by the end of the session, you will be having little idea about how to read antibiogram as well. And also, we will be having a clinical cases for this discussion, deciding between which drug will be better in which condition. Okay, deciding carbapenem versus BLBLI, very important case discussions we will be having. So in cases, we will connect all the dots all together. Okay, I hope learning objective is making sense to you now. What is coming in this session? Okay, let's start. Let's start with the culture to clinical decisions. Now, this slide is base. Okay, this slide is foundation for what is coming, what will be coming. Okay, so let's understand what really happens from the time a sample is collected to the time an antibiotic is prescribed. Again, I am repeating, from the time sample is collected to the time antibiotic is prescribed, in between what happens, we need to understand. First, sample collection. Sample is collected, whether it is blood, urine, sputum, pus, CSF, anything, right? Sample collection. If the sample itself it is contaminated or collected after the antibiotics are started, the entire report can be misleading. Understand it? Why I am showing you these things? Because errors can be also part of the report. If your report is not matched with your clinical signs and symptoms patient is having, ask yourself that yes, there can be error chances in the handling as well. Sample connection. Okay, very, very important. You need to ask always, because many time in the ward round, many time in the clinical setting, what happens, your report is not matched with what your clinical judgment is saying. Why? Because of this reason. Okay, so if the sample itself it is contaminated or collected after antibiotics are started, the entire report can be misleading. Second, culture growth. Now the lab, once the sample is collected, going into the laboratory, the lab performs a culture, okay, where the bacteria are allowed to grow. Culture means where the bacteria are allowed to grow so that we can observe the pattern, right? No growth does not always mean no infection. Okay, remember, no growth in the laboratory does not always mean no infection, guys. So this point is also important. It could mean the prior antibiotic exposure or any kind of fastidious organism as well. So that can be also the reason behind it. Third, organism identification. Once the growth is done, growth occurs, the lab further, does the organism identification. For example, is it E. coli? Is it Klebsiella? Is it Staphylococcus aureus? What exactly it is? This step is very crucial because each organism has, predictable resistance pattern, guys. Predictable resistance pattern. E. coli is not new. Klebsiella is also not new. Staphylococcus aureus is also not new. So we know, okay, laboratory person who is skilled enough, they know what is the resistance pattern behind the organism, so they can identify it. And fourth step will be AST, that is antimicrobial susceptibility testing. This AST confirms, guys, this is confirming, okay, this is confirming what will be the result. So the lab performs this AST test, and here, antibiotics are tested against the organism using the disk diffusion method. And they will be knowing, what will be the minimum inhibitory concentration required to kill the particularly the bacterial growth. So AST में क्या होता है? What will happen in AST? Antibiotics are tested against the organism. Whatever antibiotics there are, beta lactam and all, they will be used, okay, against the organism using what method? Disk diffusion. Don't dive deep into the method, guys, because we have skillful person for it, separate branches for it in the healthcare to perform these things. This is not our duty, but we must know the steps. Okay, so they are following a disk diffusion method and testing the antibiotic against the organism, and they will be having a MIC, minimum inhibitory concentration, to kill the bacterial growth. Finally, we reach to the final step, which is an interpretation. So we reach to the interpretation and therapy optimization, means therapy selection. And this is where pharmacists are playing a biggest role. Now we have report, we have antibiotic susceptibility testing report in our hand after this, four step. And now for interpretation and therapy optimization, we are here. So the lab gives us the data. They do not choose the antibiotic. They cannot. So we must interpret the report considering, considering all the factors, I will say. So considering what? Considering site of infection kya hai? What is the site of infection? What is the severity of the disease? What is MIC value the lab report is suggesting? Okay, what is resistance pattern mechanism is identified? What are the patient related factors, like whether it is renal function we need to check, hepat function we need, liver function we need to check, patient factor, right? So always remember, guys, culture report informs the therapy. It does not dictate the therapy. We need to optimize the therapy based on the report. right? So I can give you a small example to understand this whole process thoroughly. So what I can give you the example is, okay, let's imagine a urine culture. Urine culture is showing E. coli sensitive to many antibiotics. For an example, E. coli is evolving like anything. Urine culture sample collection was urine. Culture growth was identified E. coli sensitive to antibiotics. Means you can use lots of antibiotics in the E. coli. If the patient has uncomplicated condition, for example, any inflammatory condition, if the patient is having uncomplicated, oral therapy will be enough for this particular patient. But if some organism is isolated from the blood in the other sample, the treatment approach will be completely different. Urine culture is suggesting E. coli sensitive to any antibiotics, but in blood culture, if the isolated organism is showing the resistance strain, the treatment approach will be different, even with the same susceptibility report. This is what the complexity we are facing in the clinical setting. You must be aware of this whole fundamental things. Okay, so it is not like that urine culture report shows the same data as the blood culture report shows. No, there will be more complex cases. I will let you know it when whatever cases I have included, we will discuss about it. Some complex cases are coming in your way in future as well. We will be discussing lots of things related to this. Okay, first understand culture to clinical decision, how the flow goes. I hope it is clear to you. Now, we will start with our very first learning objective that I told you that by the end of this session, you will be able to understand what MIC and MIC CRIP is all about. Okay, so we will be having a quick recap as in the basic course. I have also included one whole session on the minimum inhibitory concentration. And if you were not there in the basic course, but still I can assume, because it is a concept of pharmacology, right? And I can assume that you might be knowing a little bit about MIC, a minimum inhibitory concentration, which is required to kill the bacterial growth. Okay, so this is the lowest concentration of an antibiotic, guys. Okay, lowest possible concentration of an antibiotic that is prevents the visible bacterial growth, and it is written in the report itself. So it is not a number. It is giving you some idea, okay, about the decisions you can make related to the dose. So many students are seeing this MIC and assume the lower MIC always means the better drug, but that not always true. Numeric value it is, not the decision. Okay, so here the units are also written for your reference, and you can remember that it is coming up in the mg by L and microgram per. So these are some of the units for the MIC. We will be discussing MIC in detail. This is only a quick recap that it is a minimum inhibitory concentration, lowest possible drug level inhibiting the visible growth of the bacteria, and it is a numeric value, not a decision. So MIC is not the answer alone, but still we required it. Okay, still we required it. MIC is a number, not a decision. Interpretation requires lots of things. Interpretation requires breakpoints to understand. Breakpoints is all about this SIR and breakpoints. I have included the concept in this module only. So it is coming, if it is new for you, it is coming in upcoming slides. Okay, so don't worry. We need to understand the infection site, and we need to understand the patient condition as well. So in the introductory slide of this whole topic, I already told you that we need to correlate everything. We cannot only rely on this AST report. We need to relate it with the infection site, which exactly the site is, and what is the patient's condition, whether there is some whether there is, we need to check the renal function test, we need to check liver function test and all, comorbid conditions and all, and then we can decide what will be our minimum inhibitory concentration. Okay, so for an example, to understand this, I will give you one example. See, for an example, we have one very popular combination, if you guys have idea, piperacillin tazobactam. For this combination, minimum inhibitory concentration is 8 mg per liter, right? So is it good or bad? But you cannot answer this without knowing what will be the organism, what will be the break point, what will be the site of action, what will be the patient's clinical status. If I can show you only that the MIC for piperacillin tazobactam is 8, can you solve it? Can you solve the query that whether it is appropriate for the patient or not? No, not at all. You must knowing the breakpoint site, patient condition altogether. So never ever interpret, this MIC alone. Always correlate it with your these things. Okay, how to do it? I will let you know. First, understand MIC CRIP concept. This might be new to you because this is not widely discussed, right? MIC CRIP. Let's understand what it is. This means gradual increase in MIC values over time. I am again repeating, gradual increase in MIC values over time. Now, MIC, what is MIC? Minimum inhibitory concentration, lowest possible dose. But the pattern is suggesting, if you are doing 2, 3 times the report, pattern and the trend is suggesting MIC value is increasing. So that concept is MIC creep. Now, even though the organism is still reported as susceptible to multiple drugs, this is dangerous. Obviously, if it is gradually rising, okay, this is dangerous because clinicians thinks that the drug is still working, but outcome slowly, very slowly, it is becoming worst. So CRIP concept is dangerous. Okay. So please understand again, I'm repeating MIC is a slow, CRIP is all about slow, gradual increase in minimum inhibitory concentration values over the time, even though the bacteria is still reported as susceptible. So that you can see here the very first bullet point, gradual MIC rise within the susceptible range, but you must be knowing. So even if your fellow colleague is saying that see, this report is still suggesting susceptible to antibiotics, why we are not considering it? Okay, but if you have 2, 3 reports with you and gradually MIC is rising, it is the concept of CRIP, and it is not that we cannot avoid this thing. We cannot avoid this thing, right? So it is not showing a sudden resistance, guys, but it will lead to treatment failure in future, definitely, because slowly it is rising, right? So no sudden resistance, no dramatically lab warning it is having, just very quietly, adaptation by the bacteria it is showing. Very quietly, evolving themselves, bacteria are evolving themselves, and very slowly they are rising their level. So MIC creep means the bacteria is slowly becoming less sensitive to the particular antibiotic, but not enough to be called resistance yet. Okay, we cannot say the resistant yet, but it is slowly evolving. Okay, so on the lab report, everything still looks fine. It still says susceptible, but clinically, the antibiotic starts working less effectively if you know the script concept. So think of an MIC, as how much antibiotic is needed to stop the bacterial growth. How much amount of antibiotic is needed. So at first, very little drug is needed because of low MIC. But over the time, when the bacteria adapts, it takes more drug to control the same organism, right? So the MIC increases little by little. This is MIC creep concept. So this increases, this happens within the susceptible range. That is the actual problem for us, because it is not showing you the direct things. But over the time, why the resistance are evolving so much, worldwide, and why it is burden for us in the healthcare things. The reason behind it is this script. We ignored in the past years MIC script, right? And that is the reason behind the huge explosion of the resistance nowadays in many areas. So the lab does not, this is very important concept. Why I'm saying this? Because lab does not flag this thing. Lab will say green signal. Clinicians also may not notice it, okay, because of green signal. And but patients also start responding slower in the upcoming, few months or few weeks maybe. Then the question will rise why it is happening. But this is MIC creep. So please pay attention, even if the green signal is there in the antibiogram and the susceptibility test report, pay attention to trends, pay attention to the patterns, pay attention to this MIC creep. Okay, so let's say, for example, I will give you the example. In one, first year, the MIC is showing 0.25. Second year, yearly लेते हैं for understanding, for general understanding. Second year, it is showing zero point 0.5. Third year is 1. And fourth year MIC is 2. All of these are reported as susceptible. But the drug effectiveness is clearly decreasing, clearly decreasing. And you can see here commonly seen drugs, vancomycin, very common in MRSA, methicillin resistant staphylococcus aureus case, cholestyrin. Cholestyrin is itself, it is a last resort drug. Okay, so in cases of XDR, extensive drug resistance cases, colistin and this kind of option, linezolid and all these options only we have as a last resort. And if this is happening with this agents, what will options do we have in the future? It within few months it will convert into pan drug resistance, and you don't have any option to treat further. Azoles are also in the same category. How important concept is this? And this concept is the answer for all of your question, that even if it is showing susceptible, why patient is not responding after few months or weeks to the same medicine? Because of this concept, and not many healthcare professionals are aware of this concept. As a healthcare professional, as a future pharmacist, you must be aware of this thing. Okay, and why this MIC creep is dangerous, why it matters the most? Because this MIC creep can lead to what? Obviously, silent type of resistance. You never know. Okay, and it will directly show you poor clinical response in few weeks, months, depend on its strength. It needs higher doses all the time, leads to the risk of toxicity as well. Increased toxicity. Also, clinical failure, therapeutic failure risk will be also there. And eventually, resistance. This is what we are discussing, right? This is a silent process, guys. You won't see it unless you track MIC trends. Okay, you won't able to see it unless and until you are tracking it. That's the reason I'm telling you again and again, try to focus on trends. Okay, the reports, the trends and the patterns. And even if it is green, always consider the pattern. Now let's have an example to understand this MIC creep, because it is very important. We have here the example, classic example. Obviously we will see the vancomycin, and with the MRSA, methicillin resistant staphylococcus aureus. So an MIC of zero point 0.5 usually responds well, good response. But in second, MIC1, that means clearance becomes slower. MIC2, treatment failure risk increase. So even though it may still be reported as susceptible, in this particular case of MRSA, vancomycin still considered under the green signal, guys. You can use it, susceptible, but you can see the pattern, right? So that's why pharmacists often recommend alternatives of vancomycin. Just give me a minute, guys. Just give me a minute. A call is coming. Just a minute. Okay, so I hope it is making sense to you, right? So that's why pharmacists often recommend, this if they are found, finding this pattern, they will be providing alternatives like linezolid or daptomycin instead of vancomycin, even when a bacteria is. Um, okay, just a minute, just a minute. Okay, so even when the bacteria is reported as susceptible, this higher values within the susceptible range that can lead to the treatment failure as well. That is what I'm talking about, and that is the reason behind why clinical pharmacists are there, because obviously clinician physicians have don't enough time to analyze this pattern. And also, of course, you are one who is trending in between. Okay, so let's understand this MIC crib with a very important context, why it is very important and how it is making sense, right? So please understand, this is very important in case of narrow therapeutic index drugs, right? Because the variation is very high, and you will be seeing this resistance, and you will not have much amount of dose you can increase or intervals you can reduce because of the toxicity profile of the narrow therapeutic index drugs. And this is very becoming danger problem with those agents. I hope now you have idea about MIC crib. Now, I told you that they are performing in the lab the disk diffusion methods and generating the MIC. So you need to little bit, you need to be aware of little bit what is this disk diffusion. So you have idea how exactly the MIC, minimum inhibitory concentration, is being identified. So disk diffusion, gives us the zone sizes, how big the zone is, and how what is the diameter and all. So disk is basically zone based, and it is a qualitative. Okay, so MIC gives us an I will say actual number, which is the numeric, that is a quantitative. So disk and MIC both is connected, and both is required. So in severe infections, like sepsis or ICU cases, in all the ICU cases, these MIC based decisions are more reliable. We need minimum inhibitory concentration in the number. Okay, we need a quantitatively the results, and not alone the disk based, which is a zone based, and the qualitative. In your report of AST, you will be having both sometimes. Okay, both, based on both you will be having. But as I earlier told you, in cases of sepsis and ICU cases, these MIC based decisions are more reliable, and these are two main methods I will consider for all of your antibiotic susceptibility testing, AST. And they do not give the same depth of information, guys, because both is mandatory, both are important, but generally in case of an emergency, you need a numeric and the quantitative details to calculate the dose. Okay, so you need to understand that how laboratory test this antibiotic susceptibility. So there are the two common methods for it, disk diffusion and the MIC. And we need to understand the slight difference. It is a very thin line difference. Both tells us whether an organism is susceptible or resistant. The goal is both having a same goal, but they are not equal enough. Okay, one is qualitative, second is quantitative. So I hope now you have idea. Again, I want you to discuss about disk diffusion in little detail, so that the idea will be clear to you. What happens in the disk diffusion, guys? Antibiotic, impregnated disk are placed on an agar plate on the laboratories, in the laboratories where the bacteria are growing on the plate. And after the incubation, they are measuring the zone of inhibition, the clear area around the disk, the round one. Okay, so the large one, it is susceptible. The small or the no zone, it is a resistant enough. So the result is mainly a qualitative, not numeric. Okay, so disk diffusion does not tell us how much drug is needed to kill the bacterial growth, only whether it works or no. That is what the disk diffusion is suggesting to you. Okay, whether it will work or no, because it is only showing a growth, the round shape growth. Okay, so if you are using an antibiotic drop and the zone is if the zone is large, that means the reaction is happening, so susceptible. If no, then it will be same. Okay, so this is how the result is being generated. And the second one is MIC. So MIC test tells us the exact concentration of antibiotic required to inhibit the growth. So it will give you a numeric value, better precision also, I will say, and to ability also to apply all type of PKPD principles in our context. So these MIC values are especially helpful in the serious type of infections. Please understand this. Okay, so I hope now you have idea about disk diffusion versus MIC. What's the difference? Very common question asked while handling, if you are appearing for the post of clinical pharmacist, or in, major interviewers and the Viva sections, very important section. In the cases of AST, Antimicrobial susceptibility test. What does disk diffusion is suggesting and what MIC is suggesting to you. I hope now you have idea about this. And the answer for why MIC is preferred in ICU in the cases of like sepsis and all. So what happens in the ICU patient, guys? I can say bacterial load बहुत ज़्यादा होता है, right? Bacterial load is too high in the ICU patient. Drug penetration also matters to us, and dosing also must be optimized, I can say. So this, if you have MIC value with you, so that will be guiding you whether the standard dosing is enough to kill the bacteria, whether this extended or higher dosing is needed or not. If you have the numeric and the quantitative details with you, you can solve these questions. Okay. In fact, it can show you the direction if you want to switch antibiotics or no. So, this is very important. Disk diffusion tells us if the drug works or no, while MIC tells us how well the drug will work and what is the exact strength you can start with. Okay, so that is MIC versus disk diffusion. You must be aware of. Both are important. Okay. Now, let's start with the third learning objective for the session today, and that is ESBL. Now, this is very important term, guys. When we are discussing about resistance, extended spectrum beta lactamase is very, very important. What exactly it is, let's understand. So, this ESBL are the enzymes. Beta lactamase, ACE is the word which gives you idea about that this is the enzyme. These are the enzymes that break down your extended spectrum beta lactam antibiotic. These are the enzyme generates by the bacterial body, and these are specifically generated to make the resistance to your extended spectrum beta lactam drugs, especially the third generation cephalosporin. That is the reason why they are so important to us. So, if you see ESBL in the report, automatically think about cephalosporins are unreliable in this particular category. Even if it is reported sensitive in some cases, you cannot go with it. Sometimes what happen, you will see in the report that ESBL is detected, and still, if the cephalosporin is still sensitive in the report, still some clinicians, are not prefer are not preferring and referring cephalosporin in the patient. So you will be questioning yourself why, if it is sensitive, why they are not recommended. The reason behind this is this: even if cephalosporin is susceptible in future treatment within 1 to 2 doses, again treatment failure will be happen and the relapse will be happen. Okay, so extended spectrum beta lactamase are the enzymes generated by the bacterial body, which is specifically to break down extended spectrum beta lactamase. Important is this third generation cephalosporins. It is inactivating it, right? So this is very important. And what are the ESBL common organisms we are having? So the most common we have, that is E. coli and the Klebsiella pneumoniae. Okay, Klebsiella pneumoniae. We have the Proteus pneumoniae with us. These all are common organisms which are converted themselves into the extended spectrum beta lactamase. These are very common causes for, let me say, UTI. Okay, very common cause E. coli is for UTI, urinary tract infection. Many type of bloodstream infections are associated with it. Sepsis is associated with it, which makes ESBL clinically very, very important for us. So you need to understand it, right? So these are some of the common organisms. How this is detected, how ESBL is detected. So the lab, lab suspects ESBL when the cephalosporin susceptibility decreases over the time. Okay, screening has been done for the cephalosporin susceptibility. Over the time, cephalosporin susceptibility is decreasing, so the lab is further suspecting the ESBL. Confirmation is done by showing, some improved activity, I can say, improved activity in the presence of clavonate. Okay, so confirmation is done by showing improved activity, I can say, in the presence of clavonate. And as a pharmacist, we may, not do the test, but we must recognize the pattern. We may not do the test itself, but we must need to recognize the pattern, how ESBL is evolving. So that's the reason why I'm not focused right now on what is the detection technique, what are the detection techniques, but we are more focused on how to read it. and it is directly written on the report. But you must know that what is ESBL, and if the ESBL is there, what should not be considered. Okay, what we cannot consider for the treatment. So third generation cephalosporin, right? So see this. Typical ESBL report contains what? So this is where the confusion begins, guys. How it appears. So cephalosporin R is written. That means complete resistant. Okay. Carbapenems is S, the third bullet point. That is S. That means it will be sensitive. And BLBLI, that is also S, but question mark. So that is like piperacillin tazobactam that may appear sensitive. May word is very important. May is possibility. Okay. Sometime it is written as an I as well. That is intermediate, guys. So that is also the may word, the replacement. You can use it or not use it. It is depend on the situation and patient related factors. Okay. So the question arises, can we avoid carbapenems in this or no? If it is sensitive, BLBLI is sensitive, but question mark. Can we avoid carbapenem and switch to BLBLI or no? We will answer this question shortly by in upcoming slides. You will answer this definitely because we will be diving deep into this thing. But for now, understand ESBL report. This is how it is showing. Extended spectrum beta lactamase positive, and then it will show you which antibiotic will be susceptible, which can be resistant, which can be in the question mark, and which can be intermediate. Okay, you must be knowing the interpretation. Let's cover this thing also, which is again very important. That is AMPC beta lactamase. Again, it is an enzyme, and these enzymes are not, inhibited by clavinate, unlike this the previous one, unlike this ESBL. Okay, so these enzymes are not inhibited by the clavinate. So the drugs like all I can say amoxicillin, clavinate, that will not work in this case. Even more dangerous, AMPC resistance that can be also inducible, guys. It is inducible, or you can also consider it a constitutive. So this is making the AMPC more complex to treat. And we have AMPC organism with us, which is again considered as a space. That is the full forms of the full form which is written here. We have lots of organisms which are in this particular category. So remember this mnemonic space. Okay, these organisms may look susceptible to you initially, but it is developing resistance during the therapy, especially with the cephalosporins. So if you are going to use a cephalosporin initially, within few time it will show you the resistance if it is AMPC, right? So we have Suratiya, we have Pseudomonas, we have Acinetobacter, we have Citrobacter, we have Enterobacter. This space is this, you need to remember the mnemonic for our understanding that which organisms are falling under this category. Now, I told you in this, previous slide that it is inducible. So let's understand what is inducible resistance because it is very important to understand AMPC. So this means what is inducible? Let me simplify for you guys. This means antibiotic itself, induces the resistance. Antibiotics itself induce the resistance while you are treating the patient. Now imagine the complexity of this particular thing. Okay, if you are noting it down, if the concepts are new for you, in the very first lecture, I told you to make the notes of this because it is slightly on the advanced level. Many concepts might new to you, right? So I can show you the direction in this thing. And if you have doubts, we can solve it later. But still, you need to note down everything. Okay, so some analysis you can do by yourself as well, right? So what is inducible one? This means antibiotic itself induce what? Resistance while handling, while you are treating the patient. So today the report says sensitive, but tomorrow the patient deteriorates directly. That is inducible resistance, guys. Now think of the seriousness and the complexity this concept is holding. Initial susceptibility, but resistance during the therapy, right? So that is the reason why sometime opposite scenario you will be having in the ward round. Report is suggesting something, but clinicians are not, referring. The reason behind is this complexity, right? That this is the reason why I told you in the very beginning that this is on a little bit advanced side. Now, I hope you have correlated this sentence. because we are not discussing what is happening normally. We are discussing why sometime our report is not matched with what we are looking in the prescription. Okay, so at that time we might be wondering that kuch to reason hota hoga. There can be any reason behind it, and there might be the reason behind it why they are not referring this antibiotics, even if it is sensitive, right? But the reason behind this is this concepts, and that is the reason why it is on an advanced site. Okay, so inducible resistance. What are the stewardship red flags while handling this, guys? So red flags for the pharmacist, I will consider third generation cephalosporin in the AMPC organism is very big red flag. If you are looking at it, stop immediately. Otherwise, again in future, you will be having resistance. Blindly trusting the S written in the report. Even if your report is suggesting you susceptible or a sensitive, don't blindly trust, always correlate. And the another which is not written here, but I will tell that stewardship red flag is also ignoring the bacterial identity, that is organism's identity. Sometimes they are not clinician, physician, healthcare professionals are not looking at what exactly the organism is all about. That is also the red flag. So always think beyond the report, always think beyond the report. Okay, ask, correlate, and connect all the dots all together, then you will be solving it, right? Now, what are the breakpoint? I was telling you in our previous slides, breakpoints. Okay, you must be correlate something with site of infection, patient factors, and breakpoint. What is breakpoint? So breakpoint defines whether this an MIC is susceptible, intermediate, or resistant for particular antibiotic. So they are based on all the PKPD mechanism, dosing, clinical outcomes. Okay, so it is not the just the lab data, but it is a big picture. Okay, so based on PKPD and outcomes, MIC cutoffs are defining as S, I, and R. These are nothing but the breakpoints. So till now we have talked about MIC as a number, guys. But a number alone doesn't tell us, I can say, whether we can use the antibiotic or not. This is where the breakpoint comes in. So the breakpoint is all about the cutoff MIC value decided by an expert committee that tells us below this MIC, the drug will likely work. Above this MIC, the drug will likely fail. Okay, so SINR, susceptible means drug is expected to work at the standard dose. Intermediate means drug may work at the higher doses or the specific sites. And R is completely like unlikely to work even at the high doses. So you can avoid it, right? So breakpoints are, I will consider at they are based on the pharmacokinetic dynamics, clinical outcome data, and the overall resistance mechanism. Okay, so pharmacists must care about the breakpoint, guys, because this is why pharmacists cannot just think SINR. We must always ask that which guidelines are being used. Okay, whether it is CLSI or EUCAST. Upcoming slides I will have that, so don't worry. Is the dosing is adequate enough for this MIC or not? Is the infection site is achievable with this drug? That all of the questions you must ask while handling breakpoints. Breakpoint is not the ultimate solution, guys. Okay, so a drug may be labeled as susceptible, but dose require maybe toxic, site penetration that may be poor, outcome data that may be weak. So the breakpoint help us just for our basic understanding, balancing the efficacy and safety. That's all, but we need to understand the guidelines also behind it. Okay, so for that guideline understanding, we have the next slide, CLSI and EUCST. Now the CLSI is commonly used in India, guys, and the US we have the for the Europe, sorry, CLSI is for US and India both, while EUAST that is for the Europe, and EUCST for the it is stricter guideline. Why, I will let you know. uh, First understand both of it individually. Very first, CLSI, that full form is Clinical and Laboratory Standard Institute. Okay, Clinical and Laboratory Standards Institute. This is an international organization publishing lots of things. CLSI publish guidelines actually, how to use AST antimicrobial susceptibility testing, how to do it. Okay, so CLSI published guidelines for AST, then MIC breakpoints, laboratory standards, what laboratory standards needs to be there to perform these things. Okay, and these is CLSI is generally followed in the India, USA, and many other countries as well. Right. On the another hand, we have this EUCAST. The full form is European Committee, European EU, that is European. C is Committee on Antimicrobial Susceptibility Testing, AST. So it is an European committee deal with antimicrobial susceptibility testing. This European body is responsible for again setting MIC and the zone diameter breakpoints and all. And they are also in the standardizing AST across the Europe, right? So I will consider EUCST is more stricter and more PKPD driven breakpoints, guys. Okay, they are coming up with CLSI and EUCST organizations that decides both how we can interpret MIC values and call the bacteria susceptible or resistance. How? How is based on these two things. That is the reason why pharmacists, if reading the report, they must ask which guideline it follows, either whether CLSI, whether UCST, right? So we have slide comparison also. Just a minute. I think one slide is this is the example I already give you, but just understand this breakpoint example for comparing two different guidelines. So see this, we have piperazolin tazobactam. If we have this piptazo versus E. coli. So see piperazolin tazobactam against E. coli, we are checking the example. CLSI allows higher MIC, minimum inhibitory concentration, to be called susceptible. CLSI scores is 16. If you want to use piperacillin tazobactam combination to treat the E. coli, CLSI suggesting 16, that is S, that is susceptible, while EUCST is more conservative, aiming for better clinical outcome, and it is giving you the 8, okay, which is less. It is almost half. So it is more strict, right? It is more strict. This is how the difference of guideline is all about. And why exactly this EUCST is stricter? Because this emphasizes the real world effectiveness of whole PKPD targets. And this is more PKPD driven. So this helps to prevent underdosing and resistance development. And this is followed by the European countries. You can just imagine that how much they are aware of the healthcare and the resistance. That is the only reason why our PM also, now coming up with a resistance speech, that antimicrobial resistance is rising like nothing, right? Because we are also not following stricter guidelines in the root things, guys. Okay, that is also the problem. What is antibiogram? Last topic of the discussion, as I will told you guys, antibiogram is a summary of the local susceptibility data. It is a report only, cumulative data. So this help us to choose what can be the broad spectrum antibiotic we can use thoroughly. Empiric therapy guide karta hai. This is guiding us the empiric therapy, not the definitive one. But you need to understand that it is a hospital specific, because whatever geographical area the clinical setting is having, whatever resistance pattern in that particular clinical setting they are experiencing will be there in the antibiogram. So whatever hospital setting you are working in, their own antibiogram you should be aware of. So you can understand in your geographical area what are the resistance strains which are common. Okay, so this is the role of antibiogram. How students mistakes, let's understand how students are reading antibiogram. So many students are simply pick the antibiotic with the highest percentage and choose the highest percentage of antibiotic broad spectrum, and this leads to guys overuse of carbapenem, which is a stewardship failure. Okay, and they are ignoring three other factor: breakpoint, infection site, and the patient related factors. These are some of the some student mindset I will be sharing, just to compare it with how experts are reading antibiogram. So we are, if we are at a student level, we can be choosing based on highest percentage possibility or to kill the bacteria, the antibiotic, and we are not considering the infection site, patient related factors, and the break points. Now you know all factor, right? All three factors. But how expert reads antibiogram? So expert consider what is the organism exactly, whether it is site specific or not. They are checking the infection site, patient's risk factors. So they are considering patient's fact related factors, all renal function test, liver function test. They are also checking resistance trends, and they are also checking stewardship impact, guys. This is how you need to read antibiogram like an expert. You need to correlate, you need to connect all the things. Alone report cannot do anything, right? We have example also for antibiogram things. See here, if the meropenem example is there, we have ceftriaxone, we have piptazo as well. So if the meropenem shows 98% susceptibility here in this case of E. coli, does that mean everyone gets meropenem for treating E. coli? If your antibiogram is suggesting in the hospital report that the meropenem is 98% susceptible, does that mean everyone gets meropenem? No, right? Big no. We preserve carbapenem unless absolutely necessary, of course, but we must consider the three different factors. And that's make you stewardship specialist, guys. Okay, because not you are not relying on the reports, what is report is suggesting. You are aware of the bigger picture, what can be there. Now let's coming up to the case, guys, and now we will be having applying. Now we will apply, all the things whatever we have learned till this slide. Let's apply everything. Here you can see 56-year-old patient is there with the urosepsis. Focus on the age. 56 years old, male with urosepsis, culture report suggesting the ESBL. Now you know, extended spectrum beta lactamase E. coli. Patient is stable still. So this slide, that introduce a real world clinical scenarios, guys. Okay, so you can apply MIC interpretation, resistance mechanism, breakpoint, stewardship principle here. 56-year-old patient admitted with the urosepsis. This tells us the three important things. The infection started in the urinary tract, first thing. Second, it has progressed to what? Systemic infection. That is the meaning of urosepsis. And third thing, the patient is at the risk of deterioration if the therapy is inappropriate as the age. You can focus 56. I hope you have idea about urosepsis. So this means sepsis originated from the urinary source, guys, and this is usually indicating very high bacterial load, possibly bacteremia, I can consider, and it need a better prompt and the effective antibiotic therapy. So understand, blood culture report is suggesting you ESBL producing E. coli. So E. coli is producing ESBL. E. coli is the most common cause of UTI, you know that. And this production immediately tell us that the third generation cephalosporin won't be effective. Resistance mechanisms are involved. That is the reason why it is ESBL. And empiric choices becomes limited. You cannot use much broad spectrum. You cannot do lots of things altogether. You know, so you need to check whether the patient is hemodynamically stable or not. This is very crucial in this type of things, right? Stable means there is no risk of septic shock, no vasopressor is required. Okay, some flexibility in the antibiotic choices. This is very, very important. And this case is designed to answer the stewardship question that do we immediately use a carbapenem for this ESBL infection, or can we safely use other BL-BLI combination in the selected patient? Carbapenem is generally for the last, we are considering. So what will be next? Let's look at the susceptibility report and decide, guys. We need a susceptibility report for it, not emotionally, but I will say scientifically, right? So let's understand what does AST report is suggesting. Now, ceftriaxone resistance, of course. Why? Because it is ESBL. Now you can correlate. Piperazolin tazobactam shows you MIC8 susceptible. You can use it, right? That meropenem shows again very low MIC, which is not mentioned here, but very low MIC we can assume susceptible again. So what should we choose? This is the report. Ceftriaxone, piptazone, meropenem. What should we choose? Now we are looking at actual antimicrobial susceptibility report for our 56-year-old patient, guys. The organism is ESBL producing E. coli, and the report is suggesting ceftriaxone resistant, piperacillin tazobactam 8, which is susceptible, and meropenem is susceptible again. At first glance, it looks very simple. Two drugs are susceptible, so yes, we have option. But clinically, this is where judgment is required. This is where clinical judgment is required. Now, what your thoughts are there? I want to uh, do. Are you facing any kind of disturbance in the slide, seeing in the audio? Am I audible enough, guys? Am I audible enough to you? Yes. Okay. I think someone has problem. Okay, I'm getting answer also. See, don't worry if you are not able to identify that which can be the treatment, because this is the first slide to understand the clinical judgment. I will be showing you how to do it. Next time I will, uh, you know, uh, give you idea that and ask you also for your judgment. Okay, okay, I'm getting the answer. Now, we can do a line by line interpretation, guys. Very first, chalo, ceftriaxone is resistant. Since this ESBL producer, ceftriaxone resistance is expected. Even if it was reported as, even if it was, ऐसे भी लिखा हुआ आता, if it is susceptible also, we should not trust in case of ESBL, because infection is at higher failure rate. So that is the eliminated. Second is very important, piperazine tazobactam. Now this results often, creates confusion, guys, because it is 8. Okay, so yet, yes, it is reported as susceptible, but I will say MIC is on the higher side of susceptibility. So effectiveness completely depend on breakpoint which are used, whether it is CLSI or UCST considered, what is infection severity the patient is having, right? You need to also understand some inoculum size. You need to also understand dose and infusion strategy of piperazole and tazobactam. So this is a conditional option, not an automatic choice that yes, we can go for piptaz. This is a conditional option. Let's talk about meropenem on another side. This is a very low MIC, right? Low MIC is associated with meropenem. So meaning meropenem is highly active against this particular organism. Very less concentration is required to kill the bacteria. Carbapenem are, stable against ESBL enzyme always. You can consider carbapenem are stable against ESBL, which is why they are considered the gold standard for this ESBL infection, because very less concentration you need. So why two susceptible drugs, but still it is not equal choices? So just because two drugs are labeled susceptible does not mean they are equally reliable, guys. Piperazillin tazobactam, it is on the borderline MIC. Enzyme inhibition is completely depend on the situation and the patient factor, while paropenem is enzyme stable, predictable activity it is suggesting you. So stewardship dilemma you can solve here. This is the classic example of this, confusion. Use meropenem and risk carbapenem overuse we will be following, or piperacillin tazobactam and risk of treatment failure we will bear. Next slide we'll be having a decision also, don't worry. But this is the question. We will be using meropenem and risk carbapenem overuse we will be having, or we will be using piperacillin tazobactam and risk of treatment failure. Both of the side, the advantage is also there coming up with a disadvantage. But the clinical context matters in this scenario, guys. Remember, the patient is stable. I told you in this slide, patient is stable. Source is urinary. I also told you the site of infection. I also told you MIC is known. So the decision will be, you know, uh, it will be nouns, it not be absolute, right? So let's understand clinical decision now. This is where pharmacists add value if they understood the whole mechanism. We don't just choose the strongest drug, guys. We choose the right drug. We will not choose the strongest drug, focus on peptides and meropenem. We will be choosing the right drug. So this is the most, this is the moment where stewardship thinking is required. We are not choosing the strongest antibiotic. we are choosing the most appropriate one. The decision between carbapenem and BLBLI depends on patient stability, severity of infection, MIC value, I will say risk of resistance, and stewardship goals as well. What exactly your goal is. So, this slide reminds us that antibiotic choice is the clinical decision, guys, not a lab decision anymore. Okay, so carbapenem versus BLBL and what factor matters. I already told you what factor matters. So we need to understand this slide that these are the decision factors. See this severity, MIC, inoculum, and stewardship. You need to be aware of and evidence based. Just a minute. So here we need to understand the whole case, and based on that you will be clearing that this piptazo will be your option or the meropenem. So severity of an infection, source of control, MIC value, breakpoint system, stewardship goal is the ultimate thing you need to consider for it. Both of the option answer for this question, both of the options are reliable. Depend on the patient, depend on the comorbid conditions. You need to decide. Okay. In some cases, have the broad mindset while handling stewardship cases, guys. In some cases, this the same exact scenario will be there. You will be having in prescription piptazo. In same cases, you will be having meropenem as well. Both are correct according to the clinical judgment the clinician physicians are having. But where exactly you can make an value while the resistance occurs. So you can, see the other factors like this and guide further the alternatives. If they are choosing this medicine, piptazo, with the treatment failure risk, if the treatment failure occurs in few weeks, you can consider this decision factors and you can better suggest some other, that this option, meropenem and all. So this is how you can make a very big impact, right? So what are evidence-based takeaways from this particular session? For severe infection like septic shock, carbapenem remains gold standard. For stable patient with the low MIC and controlled sources, BLBLI may considered with the close monitoring. I am again saying may consider with the close monitoring because failure risk ज़्यादा होता है. Treatment failure risk will be higher in cases of piperazine and tazobactam. क्योंकि उसका if they can use it, the treatment failure risk will be higher. MIC is 8, you can understand, right? So this is how you can correlate. Evidence based takeaway for this whole case is this only. Severe infection, of course, carbapenem gold standard. For stable patient with low MIC and control sources, BLBLI may be option, but with the close monitoring. So the key takeaway, key stewardship pearl you can, remember, that is antibiotics are a shared resource, guys. MIC trends very much matters. Crip, okay? Know the resistance pattern. Your role as a pharmacist is not to read the reports, but to interpret them wisely since the very first slide I was telling you. And that's how we protect, both today's patients as well as tomorrow's antibiotic as well. Okay, so interpret the report responsibly. So this is the end of the session today. I hope it is making sense to you and you are happy by learning this concept. Sounds little complex, but very important. Just a minute. Just give me a minute, and I will be back. Why the chat is not loading? Just a minute. Yes, I can give you access also to unmute yourself if you want to speak anything. Just a minute. Okay, I think one dose calculation handbook you were talking about, right? Yes, actually, I was trying to find the soft copy for you. I have link with me, but not able to download it. But I will share the link anyway. That's fine. Super soon.
Good evening, ma'am.
Good evening. Good evening.
Hello, ma'am. Ma'am, I have three doubts, ma'am. Actually, three doubts.
Yes, yes, say.
Ma'am, actually, the sensitivity report will be seeing through culture sensitivity report, right? Those sensitivity value, MIC values.
Yes,
Then, as you said
antimicrobial
that
sensitivity testing reports. Yes,
while teaching MIC CRIP, as you said, it's a gradual increase in MIC, right? Then how we can't do
yes.
culture sensitivity for multiple times? Then how we'll be knowing the MIC CRIP?
Sorry, just can you repeat? Actually, your voice is little bit breaking.
We can't do the test. I mean, culture sensitivity for multiple times, right? Then how come we can measure that MIC CRIP in a patient?
See,
Uh,
this is, on the basis of monthly and yearly, the trends are there. So you can compare always by, the trend reports and the anti-biogram, whatever your hospital setting is having. So it is not like that there you can recommend always to do AST, uh, simultaneously all the time. It is not possible. But as a pharmacist, as a future pharmacist, we can look into the trends. We cannot advise people and patients to have these reports on a daily basis, but we need to think in that way that these trends and these things are matters. And by seeing your hospital antibiogram, which can be updated 6 monthly, yearly, sometime quarterly as well, so you can refer that and you can compare that. Obviously it is not advisable for the patient to do it multiple times, but it is the way of the direction where you can think of, and you can check your own antibiogram patterns and testing things in your hospital setting and the clinical setting,
okay, ma'am. And ma'am,
and you can assume the treatment. Yes.
which sample is more standard to sensitize the treatment, ma'am? Specific treatment
which
specific means
which
sample, urine or blood. I mean, culture report for sample.
that is completely depend on what situation a patient is having. Okay, what is the diagnosis, what is the scenario? Based on that, the sample is which sample will be good is considered based on the infection itself.
Okay, ma'am. And the last one is, as you said, the inducible resistance.
Yes.
At first, it will be susceptible. Later, it can become resistant. You told, right, ma'am? But
Yes, and
when
hmm,
how
yes.
come we'll know that? How come we'll know the drug response? At first, it is susceptible, and later, how come we'll know it is resistant based on the TLC count?
Yes, based on many things, you can actually identify it. You will see in the normal CBC report as well, the inducible thing, because it will show you the infection is increasing, right? And also you can understand because CBC is frequently happen in the ICU daily, right? So you can understand even if the patient is having the treatment, still the infection rate is increasing. So that is the case of inducible resistance.
Thank you, ma'am.
Okay, thank you so much. Which is useful to learn more efficiently and broadly. Can I get the book which you referred? Yes, I will share you the link. I'm not able to actually download it. I want to share you the PDF, but I'm not able to download it. That's the reason behind the delay. But I will share the link so that you can read it, from the online platform. Okay. Any more questions from your side, guys? No questions? Are you
Yes,
able to understand? Yes, I think someone wants to speak. Yes. Okay, let me ask you one question. Are you able to understand what we are, uh, you know, what we are having in the lecture? The concept is clear to you or no? I want that thing. Yes or no? I want your reactions. Okay, I hope it is making sense, guys. It is very, very important, concepts. And okay, I think one question is there. How do we get to know about bacterial load? Okay, so we usually do not measure the bacterial load directly. I can say we infer it using some clinical laboratory and micrological clues. So, yes, source of infection is very important. Like the high bacterial load always, the infections is like severe cases of inflammation. You can just imagine the cases of endocarditis, pneumonia, sepsis, intra-abdominal infections and all. These are high bacterial load infections, while low bacterial is uncomplicated, cases, uncomplicated UTI, or maybe it's the skin and the soft tissue infection in an early, infection stages. Some catheter related infection, these are low bacterial load infection. So by this, source of infection also you can categorize it. And type of organism is also very important. Like certain organisms are, associated with the dense growth itself, like the ESBL is coming up with the dense growth. MRSA, right? Pseudomonas aeruginosa, these all are coming up with the dense growth. And culture report clue is also very useful. Like labs may, indirectly suggest the load by reporting heavy growth, moderate growth, scanty growth as well. So yes, these are the things to look forward with the bacterial growth. Time is also very crucial in the report. Like growth within 12 to 24 hours, it is suggesting you the higher bacterial load. While if the growth is happening more than 48 hours it is taking, it is lower burden considered. So this is how you can have this. Any value on AST suggests on this? I cannot get your question. Can you elaborate? Yes. Any more questions from your side, guys? Actually, by the 8:30, I have one more lecture in line today. From tomorrow, it will be not like from next Thursday, it won't be there. But today we have. Yes, Shruta has one question. Yes, based on clinical, what? Based on gram strain, can we start higher antibiotics? Depend on the situation, depend on the case. Multiple factors are there to consider in this, situation. I will be taking your lab medicine course, so don't worry. I am here, so you can stay here. Okay, one more question, interesting question I can read. One last question we can attend. And if you have still questions, doubt, we can solve it later, don't worry. The question is, patient culture shows methicillin resistant and he is resistant to Venco. So he was given Zostem. Is that effective and gold choice? The short answer is no. Why? Because Zostem is again a combination piperacillin tazobactam and it is not an effective or appropriate choice for the MRSA, especially if it with vancomycin resistance. Okay, no, the answer is no. Why? Zostem is not a good choice in MRSA. Very first is MRSA means itself methicillin resistance. So that means it is resistance to all type of beta-lactam antibiotics, penicillin, cephalosporin, including Zostem. So even if it looks strong, it does not work against MRSA, guys. And vancomycin resistance, again, first line therapy has failed. So you must use anti-MRSA or, non-beta-lactam agents. I hope it is clear to you. If the patient is stable, can we de-escalate or should wait until to finish the course? Depend on the situation, depend on the case, what laboratory parameter patient is suggesting. Patient's laboratory parameter kya bol raha hai, that is very important. And you need to understand the whole, the case. This is very important actually, stewardship question I can consider. Shortly, if I can say, if the patient is clinically stable, de-escalation should be done. But you do not need to wait to, finish all the time the full course on the broad spectrum therapy. And that is the de-escalation is all about, the meaning itself it is. And what, does stable mean? It is also very important. Like you can consider de-escalation only if, all are the concept like hemodynamically, if the patient is stable, patient is afebrile, improving all WBC and reports, source of infection identified and controlled hai, culture susceptibility result available hai, so you can do a de-escalation. So it is depend on the situation. I hope it is clear to you and making sense. Okay, guys. So I think if you have still questions, you can just put that questions into WhatsApp group. I will be solving it. Otherwise, next Thursday also we will be having courses. Okay. This module is the fourth number. Fifth module is also on the same principle we will be having. So yes, we will dive deep into it. Okay. Thank you so much, guys, for joining today. Thank you. See you guys on next Thursday.